Antibiotic resistance is among the greatest public health threats today, leading to an estimated 2 million infections and 2,300 deaths each year in the United States. Although antibiotics are life-saving drugs that are critical to modern medicine, infections with pathogens resistant to frontline antibiotics can require treatment with alternative antibiotics that can be expensive and toxic. Antibiotic-resistant infections can lead to an increased healthcare costs and, most importantly, to increased morbidity and mortality. The most important modifiable risk factor for antibiotic resistance is inappropriate prescribing of antibiotics. Approximately half of outpatient antibiotic prescribing in humans might be inappropriate, including antibiotic selection, dosing, or duration, in addition to unnecessary antibiotics being prescribed. At least 30% of outpatient antibiotic prescriptions in the United States are unnecessary. Sinus infections, middle ear infections, and pharyngitis, such as sore throats, account for nearly 45 million antibiotic prescriptions each year. Only half of these individuals with these infections receive the first-line recommended drugs as compared to prescribing guidelines. Antibiotic treatment is the most important risk factor for Clostridium difficile infection, also known as C. diff or CDI. In 2011, an estimated 453,000 cases of CDI occurred in the United States, approximately one-third of which were community-associated infections. As much as 35% of adults and 70% of pediatric CDI cases are community-associated. One study estimated that a 10% reduction in overall outpatient antibiotic prescribing could reduce community-associated CDI by 17%. By reducing unnecessary antibiotic prescribing, antibiotic stewardship can help prevent and avoid adverse events from antibiotics. In addition, without interventions, antibiotics will continue to become less effective or not work at all. The Lake Superior Quality Innovation Network serves Michigan, Minnesota, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. Under the contract with CMS, the Lake Superior Quality Innovation Network invites you to participate in Quality Improvement Initiative, combating antibiotic-resistant bacteria through antibiotic stewardship in communities. There is no cost to participate. As part of the task of CMS's Quality Improvement Program in this arena will include to spread the principles of antibiotic stewardship among recruited outpatient settings at the point of care where antibiotics are being prescribed. Lake Superior QIN has been working on antibiotic stewardships to prevent healthcare-associated infections and has a strong history of working in the community to facilitate transitions of care. We are offering members of the community to join our antibiotic stewardship efforts. Specifically, we are asking emergency departments, emergency services, urgent cares, and physician offices to consider joining our collaborative to reduce antibiotic pressure in the community. Our goals and objectives for this program include explaining what the goals are of our project, highlighting the benefits of your participation and the support you would receive as a partner, share how we will collect data and how we will use that data, and then finally explore a possible community collaboration opportunity. Our goals include our primary goal, which is to increase the number of outpatient settings that have incorporated all 4 core elements of outpatient antibiotic stewardship as defined by the Center for Disease Control and Prevention, known as the CDC. The core elements themselves, as well as the tools and strategies for implementing or enhancing them, will be the focus of this work. Although not an official goal, Lake Superior QIN will be monitoring the number of hospital admissions for C. difficile infections to see if they're reduced due to the decreased antibiotic pressure in the community. The Triple AIM is a framework developed by the Institute for Healthcare Improvement that describes an approach to optimizing healthcare system performance. It is IHI's belief that new designs must be developed to spontaneously pursue 3 dimensions, which they have called the Triple AIM. The first is improving the patient experience of care. This includes quality and satisfaction. The second is improving the health of the populations. And third and finally, reduce the per capita cost of health care. How do you know if you need support? To determine this, we first ask the following questions. Do your patients or the parents expect antibiotics to be given? Have your patients developed C. difficile infections? Do you want ready-made tools to follow best practice but don't have the time to search or create them? Do you want to learn about how the Quality Payment Performance Program will reform Medicare Part B payments? Do you want to learn how to participate in antibiotic stewardship so it can help you achieve a higher merit-based incentive payment system, or MIPS score? If you answered yes to even one of these, you may want to consider the program. The benefits include knowing if your facility is meeting all 4 core elements of outpatient antibiotic stewardship by gaining experience in assessing and determining which core elements of antibiotic stewardships are in place and or are needed. Each quarter, your organization will receive information and or tools on possible solutions to your barriers and gaps. This is not a cookie-cutter approach, as all facilities have unique needs. You will also receive staff education for outpatient settings on the fundamentals of antibiotic stewardships and the risks of misuse or overuse of antibiotics. In addition, we can help with skills on how to explain why an antibiotic is not always necessary. You will receive pre-made education for patients on antibiotic stewardship. And finally, acquire tools to assess and resources to implement for a successful antibiotic stewardship program. Having an opportunity to participate in antibiotic stewardship as a multidisciplinary advisory team or an antibiotic community coalition includes bringing together emergency services, long-term care, and clinics together to discuss how we can better work together. This includes networking with and learning from experts in your state and in the county. It also includes having access and participation to National Learning and Action Network, known as the LAN, activities that promote and spread antibiotic stewardship and their best practices. We also have the ability to pull Medicare FSS beneficiary data for Part B, which is outpatient settings, and Part D, drug prescription data. We have access to almost 3 years' worth of data, but do experience a 6-month lag. In order to run such reports, we would need a list of drugs you want pulled and the NPI number of that provider. We can also pull data by visit primary diagnosis and cross-reference this with Part A claims to determine if patients were hospitalized. Typically, a turnaround time is 2 weeks, and then after the first run, you would expect less than 5 days to receive such a report. The data collection includes the 4 core elements of antibiotic stewardship, and they provide a framework for antibiotic stewardship for the outpatient clinicians and facilities that routinely provide antibiotic treatment and were developed through a combination of combining evidence-based antibiotic stewardship practices in other healthcare settings and building on or adapting best-known practices across all settings. A quarterly questionnaire would be sent for your staff champion to complete electronically and will take less than 5 minutes throughout this project. It will ask the following things. In the area of commitment, we're looking for a written or display a public commitment to support antibiotic stewardship. For example, a study was shown that only with one intervention of placing a poster within the clinics stating that they were committed to prescribing antibiotics appropriately resulted in a 20% reduction of antibiotic orders that were considered appropriate. This simple display of using a poster that lets patients know that antibiotics may not always be prescribed can also be used as a form of education, but it shows the commitment of the facility to using antibiotics wisely. Another area that could be used for commitment is identifying a single leader to direct antibiotic stewardship activities within a facility. This is actually taken from the acute care setting. Another level that could be used is to include antibiotic stewardship related activities in job positions or job evaluation criteria. This method has been shown to be effective in hospitals with the duties as well as the understanding of staff members to have sufficient time and resources to devote to antibiotic stewardship. And the last area that could be done under the area of commitment is to improve antibiotic prescribing by using consistent messaging when communicating with patients about the indications for all antibiotics. This includes all staff members, from those triaging calls, the receptionist, to the nurse taking the patient into the clinic setting, and the provider. The next area is action. This includes using evidence-based diagnosis, criteria, and treatment recommendations and local pathogen susceptibilities to making decisions. Another could be using delayed prescribing practices or watchful waiting when appropriate. Delayed prescribing can be used with conditions that usually resolve without treatment, but those who could benefit from antibiotics if the conditions do not improve, such as an acute, uncomplicated sinusitis or a mild acute otitis media. While watchful waiting is for symptomatic relief without a clear plan for follow-up. I should actually say it's watchful waiting with a clear plan for follow-up for when signs and symptoms worsen or do not improve. Another item that could be implemented under action is providing communication skills to clinicians that are used to address patient concerns, while the clinician is allowed to actually help manage the patient expectations for antibiotics during the visit. Another item that could be implementing is requiring written justification in the medical record for non-recommendations that fall out of your facility's prescribing practices. This holds the clinicians accountable in the medical record for their decisions. Another area you could consider is to provide support for clinical decisions by facilitating accurate diagnosis and effective management of common conditions such as acute bronchitis in healthy adults. And another action item could include using call centers, nurse hotlines, or pharmacist consultants as triage systems to prevent unnecessary visits such as for the common cold. And why I'm talking about each one of these for commitment, action, tracking, and education, please know that any one of these bullets that I've explained could be used as a way to show that you have met the measure. You do not need every single one of the items mentioned under each category to be in place to be considered compliant for each element. The third element is the tracking and reporting. This could include implementing at least one antibiotic prescribing and tracking reporting system, such as reporting the percentage of all visits leading to antibiotic prescriptions. It could include assess and sharing performance and quality measures and establish reduction goals, addressing appropriate antibiotic prescribing from healthcare plans and payers. The National Strategy for Combating Antibiotic-Resistant Bacteria aims to reduce inappropriate antibiotic use by 50% for monitored conditions in outpatient settings by 2020. Current HEEX measures include quality measures for appropriate testing for children with pharyngitis, appropriate treatment for children with upper respiratory infections, and avoidance of antibiotic treatment in adults with acute bronchitis. Another element you could consider is for solo practices or practices with fewer than 5 clinicians, with all the clinicians participating, is allowing them to self-evaluate antibiotic prescribing practices with updated evidence-based recommendations and clinical practice guidelines. If all clinicians in the practice participate in activity tracking and reporting, you also could consider participating in continual medical education and quality improvement activities to track and improve antibiotic prescribing. The last area in education expertise is broken up into 2 different categories. And keep in mind, you do not need all elements. You could have one thing completed under patients and you would be considered compliant for this core element, or you may choose to work on the clinician end. For patients, you could use effective communication strategies to educate patients about when antibiotics are or are not needed. Providing recommendations for when to seek medical care if the patient worsens or do not approve, such as a contingency plan, has been associated with higher visit satisfaction scores among patients who expected but were not prescribed antibiotics. It could also be education about potential harms of antibiotic treatment, such as nausea, abdominal pain, diarrhea, C. difficile infections, or allergic reactions. And finally, the simple act of providing patient education materials would consider you compliant for this core element. For clinicians, you can provide face-to-face educational trainings with peers, colleagues, or opinion leaders, as well as peer-to-peer comparisons to facilitate changes in practice. Also, you can provide continuing education activities for clinicians, in particular, communication training in which clinicians are taught how to assess the patient's expectation, discuss the risks and benefits of antibiotic treatment, provide recommendations when to seek medical care if worsen or not improving, again that contingency plan, and assess the patient's understanding of the communicated information led to sustain and to decrease the inappropriate use of antibiotic prescribing. And the last one is to ensure timely access to a person with expertise. This could be pharmacists, medical providers, and even surgical consultants who can assist clinicians in improving antibiotic prescribing for patients with conditions that require specialty care. Based upon your response, your facility would be provided with tools and resources which assist the partner to meet all 4 core elements as recommended by the CDC. The triple aim concept is one in which all aspects of healthcare come together for a common purpose. So as we look at this triangle, we can see that one is representing the fact that by prescribing antibiotics when only necessary, the community benefits from less antibiotic pressure. Another quadrant is that quality is increased with the satisfaction of patients due to less antibiotic-related complications when a patient receives the antibiotic diagnostically indicated with the right drug, dose, and duration. And the final quadrant highlights that the fact of cost of healthcare is decreased due to the prevention of CDI, which can result in hospital admissions, increased length of stay, and possible readmissions. Currently in Wisconsin, the Lake Superior QIN is working with 72 long-term care facilities to support the reduction of C. difficile infections and ensure antibiotic stewardship programs are in place to meet the CMS, the Centers for Medicare and Medicaid Services requirements by November of 2017. By partnering with the Wisconsin Hospital Association, we're working with 79 hospitals on supporting the 7 core elements for acute care settings, as outlined by the Center for Disease Control, while using the best practice to reduce the events of C. difficile. Our intent is to bring together 3 groups, being emergency services, long-term care, and clinics, to discuss what communication is needed for transfer of care, as well as to understand the unique aspects of each one of these locations and support their needs. The similar models used in the United States has resulted in a better understanding of patient and resident past medical history of infections, such as active infections versus colonizations, better understanding what key information is needed by the receiving information, and an overall reduction of C. difficile in the community and healthcare facilities. We do not anticipate starting this coalition until late in 2017 or early 2015. So what's the catch? Well, we do ask that your facility remain active in this initiative through July of 2019. And we do ask that you grant us the permission to acknowledge the participation of your facility in this initiative. In order for your facility to reach the highest level of commitments, we ask that you form an interdisciplinary team to incorporate all core elements of outpatient antibiotic stewardships into practice. We ask that you identify a clinical lead who will provide antibiotic support form as an executive level decision maker and a staff champion who will manage the antibiotic stewardship program. We ask that you participate in educational opportunities, webinars, and conference calls when you're available. We ask that you collaborate with fellow healthcare providers in your geographical area across various settings of health to enhance antibiotic stewardship in your community. We also ask that you share your best practices, your results, as well as what lessons you have learned. And finally, we ask that you ask for help if your organization is struggling to move forward. If your organization is ready to start this project, copy the electronic participation agreement web address and paste it in your browser. You will need to have basic information on hand, such as facility name and address, but also each clinic's CCN number, or for individual providers, their TIN. You will need to identify the following key roles: outpatient setting clinical leader. This can be an executive, administrator, or owner who is committed to engaging staff and help implement clinically relevant antibiotic stewardship activities and oversees the results. You will also need to identify an outpatient setting staff champion. This could be a physician, nurse, or pharmacist, as well as their titles, phone numbers, and email addresses. After we receive your participation agreement, we will contact you to start your outpatient antibiotic stewardship journey. Although the core elements provide a framework for outpatient antibiotic stewardship, implementing the core elements requires a thoughtful and consistent effort to achieve desired outcomes. This includes developing strategies and preparing individuals, facilities, or organizations for change, developing and testing stewardship interventions, identifying and addressing barriers to change, and evaluating progress towards stated goals. Outpatient settings remain a critical component of antibiotic stewardship in the United States. Establishing an effective antibiotic stewardship intervention can protect patients and optimize clinical outcomes in outpatient health settings. Do you still have questions, concerns, or need additional information? Please feel free to contact me, Deanne Richards, via email or by phone. Thank you for your time, and have a wonderful day.